Hi, this is the recorded version of Lecture 6, which is an introduction to anxiety disorders and specific phobia. So we're going to start by just talking in general about what anxiety disorders are and what some of the predisposing factors to anxiety are. First, some epidemiology. So these are just 3 examples of nationally representative studies conducted in the United States that tried to estimate the point prevalence and the lifetime prevalence of anxiety. The point prevalence is roughly the number of people who have an anxiety disorder right now, whereas the lifetime prevalence is the number of people who have or have had an anxiety disorder in their lifetime. The exact numbers aren't that important here. As you can see, there's kind of a lot of variability across these 3 studies in the exact estimates that they arrived at. The important thing to note is that anxiety is relatively common. Somewhere between 8 and 20% of people in a given year meet criteria for an anxiety disorder, and that number goes up to 15 to 35% in their lifetime. Population-based epidemiological studies like this that ask people to remember their past and report on whether they've ever had a disorder tend to underestimate disorders like anxiety and depression that have chronic but relapsing and remitting courses. What that means is that anxiety doesn't tend to go away if it's untreated, but it does tend to fluctuate in its severity, often in response to life stressors. So when people are surveyed by epidemiologists and aren't currently anxious, sometimes they aren't great at remembering times in their life when they have been anxious. So 34% is possibly an underestimate of the lifetime prevalence of anxiety. The important point to remember is that anxiety is common. Anxiety is also highly comorbid. So someone with any given anxiety disorder is likely to have another anxiety disorder diagnosis or depression, or another psychological comorbidity. Anxiety disorders are also highly comorbid with medical disorders, especially medical disorders like migraine, GI disorders, as well, and a lot of chronic illnesses. When we talk about the predominant emotions and the emotions that are dysregulated in anxiety disorders, the main ones are fear and anxiety. Fear is a visceral physiological response to immediate danger. It's what your nervous system does when your life is imminently being threatened, when there's a clear and present danger in your environment. Fear is an activation of your fight or flight response. It's your sympathetic nervous system completely taking over all of your body's functions and redirecting all of your body's energies to survival. Anxiety is a less extreme, more future-oriented state of physiological arousal. Cognitively, we experience it as anxiety, worry, apprehension, dread. Physically, whereas fear feels like immediate terror, have to run away right now, anxiety might feel like being restless, being kind of irritable, being easily distracted. When an organism is in an anxious state, it's primed to have a fear response. The sympathetic nervous system is a little bit activated so that it's easier to cross the line into a full-blown fear response than when you're in a totally calm state. Anxiety is your body's way of preparing for danger that isn't present yet. So most of the disorders that we're going to talk about in this class are basically overextensions of behaviors and responses that were adaptive in our environment of evolutionary adaptation, and that may still be adaptive. And that's obviously true of fear and anxiety. They are emotions that help us survive in dangerous situations. They helped our ancestors rather, survive immediate dangers like being chased by a predator and anticipate, avoid, or prepare for future danger, like going out hunting in an area where they expected predators to be. Ancestral hominids or organisms further back in our evolutionary history than hominids who didn't have anxiety and fear responses wouldn't have survived in a natural environment. So in the first part of this lecture, I'm going to go over some of the risk and etiological factors for anxiety. These are factors that contribute to the development of anxiety and that make a person more likely to develop an anxiety disorder than other people. These are also known as predisposing factors. I'm not going to get into the specifics of neurotransmitter systems, but just briefly, neurotransmitter systems that upregulate arousal, that make the body more aroused, that activate the sympathetic nervous system, like corticotropin releasing factor and noradrenaline, are associated with greater predisposition to anxiety, and functioning of the GABA and serotonin systems in the brain, which help to regulate resting state functions and calm down arousal, are associated with less vulnerability, protection from anxiety. There are genetic individual differences in the functioning of these neurotransmitter systems that come from lots of different differences. So for example, genetic differences in the number and type of receptor that's expressed on neurons in different parts of the brain can influence the functioning of a neurotransmitter system, either making it more effective or less effective. So too can the enzymes that break down neurotransmitters in the synapse and the molecules that help transport neurotransmitters around the synapse and around the cell. The systems that we are going to talk about are the Hpa axis and the behavioral inhibition system. The Hpa axis is one arm of the autonomic nervous system, the sympathetic branch, that helps to regulate and control our body's response to stress. The behavioral inhibition system is a network of brain regions centered on the limbic system, so within the central nervous system. We will talk about a couple psychological risk factors, including an individual's beliefs about the world, whether it's dangerous, whether it's uncontrollable, and individual differences in the biological and cognitive machinery in our brain that supports learning. In this case, fear learning or safety learning that helps to override fear learning. And then lastly, there are environmental predisposing factors, particularly chronic uncontrollable stress, and particularly when that stress occurs during childhood. We'll also talk about a couple of parenting factors that can help to modify the influence of stress on a child's development, including parental modeling of anxiety or coping with anxiety, and parents' role in preventing children from being exposed to stress. So as we talked about in our introduction to the nervous system, the autonomic nervous system is the way that our brain helps to control our bodily functions. It helps to control the movement of blood around our body and the activity of our organs. The autonomic nervous system has two branches that basically control stress and arousal, the sympathetic nervous system, and that is in control most of the time, that controls our resting state, homeostatic functions, the parasympathetic nervous system. So individual differences in the functioning of each of these branches of the autonomic nervous system can contribute to an individual's predisposition to anxiety. Across the board, in everyone, regardless of how sensitive or not their sympathetic nervous system is, when an organism is experiencing the emotion of anxiety, the emotion of fear or panic, and when an organism is engaging in avoidant, inhibited behavior, the sympathetic nervous system is activated. The sympathetic nervous system helps to regulate those types of emotions and behaviors. When an individual has a sympathetic nervous system that's more sensitive, that's more likely to respond to environmental stimuli, that responds more strongly, and that has a longer lasting, more pronounced response, that is a vulnerability or predisposing factor to anxiety. It just means that when that individual feels fear or panic, that feeling is stronger, and they're more likely to have that feeling in response to stressors or stimuli in the environment. On the other hand, individual differences in the functioning of the parasympathetic nervous system can also contribute to protection from anxiety and risk for anxiety. So the job of the parasympathetic nervous system is to, in part, to help regulate autonomic or sympathetic arousal. When the sympathetic nervous system has been activated, that activation shouldn't persist beyond the stimulus. So it shouldn't last longer than the exposure to the stimulus that triggered that activation. Once we're safe, once we've escaped from the threat, the parasympathetic nervous system should take over, downregulate the sympathetic nervous system, and help to restore our body's normal resting state functions. So people who have a relatively weak parasympathetic nervous system, a lack of parasympathetic control over the sympathetic nervous system, may also be vulnerable to anxiety. Whereas people whose sympathetic nervous system is really good at monitoring and regulating sympathetic arousal may actually have protection from anxiety. The Hpa axis is one branch of the sympathetic nervous system, one way that the central nervous system, the brain, helps to control and regulate our body's arousal and our response to stress. Sympathetic activation is very intense and short-lived. The downstream effect of Hpa axis activation tends to last a little bit longer. So the Hpa axis is involved in our body's response to acute stress. When the central nervous system registers a stressor, it triggers a cascade of responses that start in the hypothalamus and end in the adrenal cortex. The hypothalamus communicates with the anterior pituitary, which is a gland that helps to release a lot of different hormones into our bloodstream. The anterior pituitary is kind of a way that the brain basically dumps chemicals into the body and controls physical responses. ACTH, adrenocorticotropic hormone, when it enters the bloodstream, it eventually reaches the adrenal cortex, where it binds to cells in that cortex and causes those cells to release the hormone cortisol. Cortisol is our body's way of responding to stress. It plays a role in our immune system. When we're having an inflammatory response to an infection, cortisol is one of the hormones that's helping to maintain that inflammatory state. It also helps us respond to stress. It helps to keep the sympathetic nervous system activated. The other thing cortisol does, importantly, is it feeds back into the anterior pituitary and into the hypothalamus by crossing the blood-brain barrier and binds to receptors on the neurons that release CRH and ACTH. And the effect of cortisol on those neurons is inhibitory. When cortisol binds to its receptor in the hypothalamus and in the anterior pituitary, the message it sends is stop releasing CRH, stop releasing ACTH. The stress response is already activated. We don't need to keep telling the body to be stressed. The body is stressed. Once cortisol shuts down CRH and ACTH production, eventually the cortisol that's already in our bloodstream will degrade. It's not immediate. It's not as fast acting as parasympathetic control returning, but it should be a self-limiting process. So individual differences in the strength of that initial response, the amount of cortisol that our brain tells our body to produce, or individual differences in the ability of the hypothalamus and anterior pituitary to respond to those negative inhibitory feedback mechanisms and stop producing CRH and ACTH in response to cortisol, can influence how intense and how long-lasting our stress response is. As we'll talk about in the depression lecture, the environment also plays a role in the functioning of the Hpa axis. When an organism is constantly stressed and constantly encountering new situations that cause the hypothalamus to initiate a stress response via the Hpa axis, it can enter what's known as a state of hypercortisolemia, where cortisol is constantly being released into the bloodstream and constantly binding to the receptors on the hypothalamus and anterior pituitary. Receptors can basically get worn out by having too much activity. So when there's too much cortisol binding in those regions, the neurons get less sensitive to that inhibitory message. So it takes more cortisol and longer signaling for them to stop initiating the Hpa axis cascade. So as we'll talk about in the depression lecture, chronic environmental stress can damage the inhibitory feedback mechanism of the Hpa axis and lead to an individual being more prone to having strong, lasting stress responses. So the Hpa axis and the autonomic nervous system have to do with how the brain communicates with the body. The behavioral inhibition system has to do with how the brain takes in information and creates new networks within itself. Basically, it helps to regulate learning processes. So reinforcement sensitivity is this theory that there's basically two systems within our brain. And these systems involve the communication of lots of different neurons and brain regions. So there's no actual area in our brain that maintains the system. It's a widespread system of networked neurons and structures like the limbic system. But the job of the job of these two systems, the behavioral inhibition system and the behavioral activation system, is to mediate both unconditioned behavior and emotions, and also to help organisms learn from punishment and reward, to either engage in behaviors less often or more often based on how the environment responds to those behaviors. The behavioral inhibition system is especially relevant to anxiety. It is mostly located in the limbic system, the amygdala and hippocampus. So the behavioral activation system also is strongly mediated by the hippocampus. In terms of unconditioned responses and unlearned behaviors, the behavioral inhibition system governs neophobic behaviors, so organisms being sensitive to novelty, not seeking out novelty, being inhibited in response to novelty. It helps to mediate our emotional response to unconditioned fear stimuli. So these are fearful emotional responses that organisms don't have to learn, that are kind of automatic and inherent. Just like inhibitory behavior in response to novelty is unlearned. Everyone is kind of born with the tendency to be inhibited in new and unfamiliar situations. In terms of operant conditioning, the behavioral inhibition system is the part of our brain that responds to and processes punishment signals from the environment. as well as non-reward signals. So not so much a negative outcome of a behavior, but a lack of a positive outcome. The behavioral inhibition system, basically one of its jobs is to teach us what not to do, teach us what behaviors are not rewarded, teach us what behaviors are punished. When an individual has relatively greater or dominant behavioral inhibition activation compared to their behavioral activation, that means that they're more sensitive to punishment, less likely to seek out rewards, less likely to seek out novelty, less likely to take risks that might be rewarded, and importantly, more prone to developing negative conditioned associations. Their nervous system is better at learning to be afraid of things and better at learning to avoid behaviors, to not do things because they might be punished. Someone with a stronger behavioral activation system would be sort of insensitive to punishment. They would be more likely to try things again and again, even if they got punished. And they'd be more likely to take risks, more likely to seek out novelty, and less likely to learn fearful associations. So less likely to learn to fear conditioned stimuli in their environment. So of course, these systems are not operating in a bubble. They are, both the autonomic nervous system and the behavioral inhibition system are processing and responding to information from the environment. So one of the most potent risk factors, environmental risk factors for developing any psychopathology, but especially anxiety, is chronic uncontrollable stress, particularly during childhood. When stress is experienced as relatively more controllable, when an individual feels like they have some agency over it or some ability to control the situation, leave the situation, manage the situation, influence their environment, influence the source of stress in their environment, that stress has a less negative effect. So an example would be from these images, being a competitive high school athlete is very stressful. There's a lot of pressure, there's a lot of hard work, a lot of physical training, a lot of uncertainty and anxiety involved. But that stress tends to be experienced as controllable. It's something that kids want to do. It's something that they get a lot of positive feedback and reward from. It's something that they can stop anytime. Contrast that with having a part-time job in high school where you need to work in order to feed your family or pay for your own costs of living. That type of stress is uncontrollable in that it's not necessarily something you chose. It's not central to your identity. It's not also a source of mastery and fun. It's just something that you have to do that you can't really control. So parents play a really important role in influencing whether their children experience different stressors as controllable or uncontrollable. When parents model an anxious response to stressors, when parents freak out in response to environmental stressors in front of their kids, that gives their kid the message that this stressor is so serious and so uncontrollable that my parent, one of the people that I trust to help manage my environment and take care of me, can't handle it. That must mean that it's very serious and very dangerous. So when we talk about the heritability of anxiety, anxiety is highly heritable. Much of that heritability comes from biological predisposing factors that parents pass on in their genes, but a lot of it comes from the environment that parents create and the influence on a child of seeing their parents have an anxious, overwhelmed response to the environment. On the other hand, or not really on the other hand, relatedly, parents who are anxious themselves are more likely to be overprotective of their children, to try to shelter their children from experiencing any stress at all, rather than allowing their kids to experience age-appropriate stress that the kids have the tools to be able to manage and control. When children are not able or are never allowed to experience stress in their environment, they never learn how to cope with it and how to manage it. And so any stressors they experience later are experienced as uncontrollable. So a big focus of this lecture will be individual differences in the ability to form conditioned associations, as well as operant learning. So we're not going to talk that much in detail about it here, but we'll talk about it later as both a predisposing factor and potentially also a perpetuating factor of anxiety and specifically specific phobias. Another psychological risk factor that really interacts with biology, the environment, and learning machinery is an individual's belief system. Their beliefs about the world, how they interpret events that happen to them, what they expect will happen to them in the future. To kind of boil down the belief system that makes someone vulnerable or predisposed to anxiety, it would be just an assumption that the world is dangerous and an assumption that I'm not in control of my life, or I can't control the way that I respond to the world or the way that I interact with the world. This type of belief system is influenced by an individual's biology. So someone who has a really easily triggered sympathetic nervous system, a parasympathetic nervous system that's not good at calming it down, an HPA response that leads to them feeling constantly stressed out because their cortisol is not able to have its negative inhibitory effect in the brain. Understandably, they could come to the conclusion that the world is a dangerous place or that they can't control their emotions because they are living in a state of chronic stress and anxiety. For people with, or independently of, but also interacting with that biological vulnerability, is environmental stress. So someone living with chronic uncontrollable stress, again, is being shown that the world is dangerous and that they can't control their stress level. Parenting, modeling, explicit teaching, or parental control that prevents kids from learning to cope with the world and learning to master their stress can also lead to this belief. And then lastly, people who have cognitive and biological machinery for learning that leads them to form a lot of negative conditioned associations, that leads them to be very sensitive to punishment and non-reward, and that makes it difficult for their nervous system to habituate to their environment and stop responding to meaningless stimuli, experiences a lot of anxiety in their day-to-day life, a lot of fear, and that can inform the belief that the world is dangerous. Human belief systems are basically our way of explaining the world to ourselves. And none of these predisposing factors destine someone to come to the conclusion that the world is dangerous. And actually, this type of belief system is one of the points of intervention in cognitive behavioral therapy, trying to help people modify this belief system and try to change the lens that they are viewing the world through. So this is kind of our biopsychosocial model of all the factors that can predispose someone to anxiety. These factors don't act independently of each other. They all interact. They have reciprocal interactions where each one influences the other and is influenced by the other. Conditioning and habituation, so differences in learning machinery, are in the middle of this network because they're strongly influenced and basically inseparable from biology, psychology, and the environment. Our brain's nervous system's ability to learn and form conditioned associations is a biological feature. It's encoded in our genes. But the way that psychologists work with and try to alter learned associations and learned behaviors is very psychological and behavioral. So we're not trying to alter people's conditioned associations at a neural level, although they do exist at a neural level. We're working with them at more of a psychological level. And then lastly, these associations come from experiences in the environment. They don't come out of nowhere. So biology, psychology, and the environment are all key to producing an individual's kind of repertoire of conditioned associations and learned behaviors. And those associations and behaviors in turn are kind of the basis of anxiety disorders. Okay. So now we're going to talk about specific phobia. The sort of clinical definition of a specific phobia, the somewhat artificial category that we placed over a spectrum of behavior and experience, is an excessive fear of a specific object or situation that exceeds the actual danger posed by that object or situation. So basically, I mean, almost everyone can think of something that they're really scared of, but being really scared of sharks when you're in the middle of the ocean is not excessive. It's not maladaptive. Whereas being really afraid of sharks to the extent that you won't even dip your toe in the water at the beach does exceed the actual danger posed by that situation. If you're at the beach and you're the only one who's afraid to go in the water, you can kind of see that that behavior is deviant because nobody else in that situation is experiencing that same fear to that same degree. The sort of more specific diagnostic criteria that make this type of excessive fear a clinical phobia are first that the fear is unreasonable and excessive, but also that when an individual is exposed to the situation or object that they fear, they have an immediate fear response. This can be anywhere from very intense anxiety to a full-blown fight or flight response, but the key is that it's immediate and it's triggered every time in that situation. People with specific phobias engage in a lot of avoidance of the thing or the situation that causes their fear. Or if they can't avoid it, they experience really extreme distress when they're exposed to it. And all of that, the unreasonable excessive fear, the anxiety response, the avoidance, the distress, all of that leads to impairment. A phobia can't be diagnosed without evidence of distress and impairment. Epidemiologists, when they study phobias and their prevalence, break phobias down into categories, and the DSM does this too. So natural or environmental phobias have to do with fears of naturally occurring phenomena like storms or like heights, or being in tight spaces or being in deep water. Situational phobias have to do with more specific situations like going to the dentist, going to the doctor, flying on a plane, driving over bridges. Blood injection injury phobias are kind of a special class of phobia that I talk about in the discussed mini lecture and that Davey talks about in the reading for Wednesday's class. So blood injection injury phobias are extreme fear responses, but also usually a disgust response to the sight of blood, to needles or getting injections, or to any kind of bodily injury. Animal phobias are sort of further broken down into large animal phobias like fears of dogs, fears of horses, fears of cats, and small animal phobias, which are more often linked to disgust in addition to fear. So things like phobias of rodents, phobias of bugs and snakes, phobias of slimy things. And then there's this big other category that encompasses common phobias that just don't fall into one of the other four categories, but also unusual idiosyncratic phobias that don't follow all of the typical patterns of phobias that we'll talk about later in this lecture. So some epidemiology, and again, these numbers are just estimates that vary across studies, so you don't need to memorize them exactly. Just know, one, that phobias are very common. So as many as 5 to 10% of people meet criteria for a phobia in a given year. And the lifetime prevalence is actually not that different from the yearly prevalence, and that's because phobias tend to have a chronic course if they're not treated. In addition to that, phobias are often kind of a lifelong affliction because they begin in childhood. And as I may have neglected to mention on the epidemiology slide, somewhere between 30 and 40% of people with anxiety disorders are able to access treatment, leaving 60 to 70% of people with untreated anxiety, including phobias. So in phobias, a lot of the impairment stems from behavior designed to avoid the phobic situation or object. If you have a phobia of a situation that you realistically will never be in, like say that you're absolutely terrified of kangaroos and you don't live in Australia, you don't have to go to the zoo. It's not going to get in the way of your job or your family functioning. If you take your kids to the zoo, you can just, bypass that enclosure. So having a kangaroo phobia, while it might be deviant and you might be really distressed when you encounter a kangaroo, might not cause that much impairment if you don't live in an environment where you encounter them a lot and where you have to go out of your way to avoid them. So phobias that tend to bring people into treatment are phobias of situations that are difficult to avoid, because that impairment really is driven by avoidance or by the inability to avoid. An example of this is dental phobia. So this is from a study that I was a part of when I was in grad school, where we surveyed patients going into dental clinics in New York City. And somewhere between 2.5 and 4.5% of the people in these clinics getting dental treatment rated their dental anxiety as a 9 or a 10 out of 10 in terms of how much they feared going to the dentist. So that was our study's kind of arbitrary cutoff for determining whether someone had potentially clinically significant dental fear, if their fear was very extreme. What we found in that study was that people who had dental phobia, people who had these really high levels of dental fear, were more likely to be at the dentist for reasons related to pain or for dental emergencies, or they were there for really extensive dental work. And this is because, our hypothesis, our interpretation of that data was that people with dental phobia avoid going to the dentist for routine things because they're so afraid of that situation, that the only thing that brings them to the dentist is an emergency or unbearable pain or needing dental work to save their teeth. So the avoidance of the dentist actually ends up leading to a lot more impairment down the line. It also helps to reinforce the fear. If you never go to the dentist for routine things like cleanings and x-rays, and your only experiences at the dentist are really painful emergency situations, needing a lot of work, that reinforces the belief, the fear that the dentist is a scary place and bad things happen there. Another example of avoidance driving the impairment of a specific phobia is vomit phobia or emetophobia. So emetophobia is one of the phobias that falls into that other category. So we don't have great prevalence estimates for how common it is. But studies have suggested that maybe around 1% of the population or a little bit less meets clinical criteria for having this phobia. They experience a lot of avoidance, a lot of distress on being exposed to cues related to vomiting, and a lot of impairment from their fear. But at subclinical levels, so just moving a little bit over on that distribution of vomit fear, out of the fully clinical range, but still a little far away from average, somewhere between 2 and 7% of people say that they have elevated fear of vomiting. And it's probably more common in kids than adults. So people with emetophobia engage in a ton of avoidance, even though their fear is very focal and specific to this one event that doesn't really happen that often to most adults. People with emetophobia tend to avoid all kinds of activities and experience extreme impairment because of this avoidance, because of the way that it limits their lives. So people with emetophobia may avoid medical procedures. Actually, they may also avoid going to the dentist because they're afraid of having their gag reflex triggered. They may avoid taking medications that have nausea or vomiting as a side effect, which if you look at the side effects of any medication, almost all of them have that as a side effect. They might avoid travel because of fears of getting sick away from home or fears about getting sick in like an enclosed space that they can't escape from. They might avoid activities like going to amusement parks or riding on boats. And a lot of women with emetophobia will say that they avoided or put off getting pregnant because of a fear of vomiting. But one of the most common forms of avoidance in emetophobia, and a type of avoidance that one of the people in the patient perspectives talks about in the videos that I'm going to have you watch, is avoidance of eating. Lots of people with vomit phobia avoid eating to limit the likelihood of throwing up, or they don't eat certain things because they think they're more likely to make them throw up. So as many as a third of people with emetophobia avoid eating to some degree, and that makes emetophobia one of the most common causes of an eating disorder called avoidant restrictive food intake disorder that puts a lot of people, especially kids, in the hospital for underweight and malnutrition. So the rest of this lecture is going to really focus on the origins of specific phobia, the etiology, where they come from. You may remember from the Tamimi article that Tamimi argued that our psychological diagnoses don't really take etiology into account. That is much less true of specific phobias than it is for some diagnostic categories. We actually know a lot about where specific phobias come from, and that understanding of etiology really informs the way that we treat them. So we just talked about why some people are more vulnerable to developing phobias than others. There are these kind of general biological predisposing factors that make it more likely that someone will have an anxiety disorder. Factors related to the intensity of our fear and stress response, our ability to form negative conditioned associations, our ability to develop punishment learning, our tendency to be inhibited in novel situations, having a stressful childhood environment, having parents who are very anxious, having negative beliefs about the world, and having this kind of biological learning machinery that leads us to form fearful conditioned associations and learn from punishment. But all of those biological risk factors are actually pretty general. They predispose you to developing an anxiety disorder, but not necessarily specific phobia. Specific phobias often have a specific precipitating event. Compared to other anxiety disorders and other psychopathology in general, it's often easier to pinpoint the exact cause of a specific phobia. So phobias typically have what we call a conditioning event, where a person learned an association between an object or a situation and a fear response. Sometimes it's from direct experience. So we break this down into true alarms and false alarms. Some phobias do come from having a life-threatening or otherwise really scary experience with a phobic object or situation. So for example, developing a dog phobia after being chased or bitten by a vicious dog. That would be a true alarm. It's appropriate and understandable to be really scared in that situation. But when you develop a fear association and learn to be afraid of dogs in general, then it can cross the line into being a phobia. Phobias may also develop through false alarms, where an individual just happens to be really anxious or have a panic attack, in the presence of a stimulus or in a novel situation. And even though the stimulus or situation wasn't dangerous, the fact that that person had a fear response caused by something else, but that fear response was paired with a new object or situation causes them to develop a conditioned dissociation to fear that object or situation. That object or situation becomes a negative conditioned stimulus. Similarly, some people develop phobias through watching others have negative experiences or watching other people have false alarms in the presence of phobic objects. Arguably, although people with vomit phobia would disagree, vomiting or seeing someone else vomit because they have food poisoning or just like a normal childhood GI bug isn't a true alarm. It's not necessarily a dangerous situation. It's just a really unpleasant and uncomfortable one. So people who develop specific phobia of vomiting after seeing someone in their life throw up, that would be an example of a vicarious experience leading to a negative conditioned association between vomiting and potentially the context that they had that experience in and a fear response. Not everyone with phobia can pinpoint a specific experience that they had. Sometimes that's just a memory deficit or they were pretty young when they had the experience, but other times it wasn't just one experience. Sometimes phobias can develop through sort of repeated pairings of an object or situation and negative emotions, negative experiences, and you can't say exactly which pairing it was that caused the phobia. They kind of all came together to cause it. And sometimes people can develop phobias of something without ever having encountered it, either themselves or vicariously. Some phobias may be taught through explicit teaching or modeling, much the way that disgust responses are taught to children by seeing their parents respond with the emotion of disgust to different stimuli in their environment. When parents tell kids, this is really dangerous, you shouldn't do it, that can be enough for some kids to lead them to have a fear response when they encounter that situation. It may also be the case that having that fear response because they were told that the situation was dangerous then goes on to actually create a negative conditioned association where now that situation that they were told was dangerous is a conditioned stimulus for fear, because due to their belief that it was dangerous, their expectation that it was dangerous, they had a fear response. That fear response led to the development of a negative conditioned association. So another question that we ask about when we're thinking about where phobias come from is, why does it seem like there are certain situations or certain objects that people are more likely to be afraid of than others? Why are so many people afraid of flying? Why are so many people afraid of the dentist? Why are so many people afraid of blood and needles? The common things that people have phobias of do actually relate to danger in some way. People tend to have phobias of situations that could be dangerous under the right circumstances or that were dangerous for them at one time. Most phobic objects or phobic situations are potentially dangerous. The fear in a phobia, though, has to be excessive and unreasonable to the situation. So people react to a situation that's not dangerous, but that's similar to a dangerous situation as if they were in the actually dangerous situation. So having a fear response when you're dangling off of a cliff and your rope is slipping is adaptive and not deviant and not impairing. In fact, it's probably an appropriate response that might help you save your life in that situation. Having that same level of fear response because you're standing on the 5th floor of a parking garage and you're near the edge is inappropriate and excessive to the situation. It's likely to cause impairment because nobody wants to feel fear, so you're likely to try to avoid being in that situation in the future in ways that could end up limiting your life. So this ability of people to form phobias or develop phobias of situations that are actually dangerous has an evolutionary basis. This is a universal tendency of humans to have phobias of certain objects, and that tendency is shared with our primate relatives. So primates learn to fear some objects and situations more readily than other objects and situations. And those objects and situations usually correspond to the real dangers that they face in their natural environment, their environment of evolutionary adaptation. So preparedness to develop phobias, to develop a negative conditioned association with an object or stimulus, is an evolutionary adaptation that helps apes, that helps primates, that helped our ancestors survive in the environment of evolutionary adaptation. So an example of an experiment that has been done to demonstrate preparedness of conditioned fear association, researchers took a bunch of baby capuchin monkeys who had been raised in a lab and whose parents had also been raised in a lab. So none of these monkeys had any direct or taught experience with their natural environment. In their natural environment, snakes are one of their biggest predators. But these monkeys had no way of knowing that snakes were dangerous because they'd never encountered one and they'd never met another monkey who had encountered one. So these baby monkeys were presented with a toy, either toy flowers or a toy snake. As they were handed that toy, the researchers played a really loud, scary noise that caused the monkeys to have an unconditioned fear response. Because they had unconditioned fear responses in the presence of this novel object, they developed a conditioned fear association to either flowers or snakes. But it took longer for them to develop a conditioned fear association to flowers. It took more pairings of a scary noise and flowers for them to learn that it was something to fear. For snakes, the learning was pretty immediate. It only took one or two pairings of a snake and danger, or something that signaled danger, the loud noise, for them to learn to fear snakes. The fear of snakes also lasted longer. So when the monkeys were able to handle the toys without any kind of unconditioned stimulus, without a loud noise being made, their fear of flowers went away much faster than their fear of snakes. So again, this is demonstrating preparedness because these monkeys had never seen snakes before or toy flowers, but they were biologically hardwired to learn to fear snakes a lot more readily than they were to learn to fear flowers, because in their evolutionary environment, snakes were their main predator. So this is, of course, true of humans too. The common phobic objects are things like predators or illnesses, injuries, life-threatening environments, like being out in the open for our hunter-gatherer ancestors was really dangerous because it meant that you were vulnerable to large predators. Being in deep water was dangerous because our ancestors lived on land. So we know that there are certain situations that we're more prepared to be afraid of, but how does one negative experience with something turn into a phobia? How does that initial fear learning develop into a clinical disorder? So we're going to talk about the two-process model of phobia development, and we're also going to talk about how individual differences in that cognitive biological learning machinery sort of work together to help people develop phobias. So just as a reminder of how phobias develop, in one of our early lectures, we talked about Freud's case study of little Hans, who was afraid of horses. When Hans first saw horses, he didn't have any kind of reaction to them. They didn't cause him to have an emotional response. They were neutral. But one day, Hans saw a horse die in the street, and he had an unconditioned reaction to seeing that death. Death is an unconditioned stimulus for fear, and the unconditioned response to it is fear. It just happened to be paired with a horse. So for Hans, that unconditioned reaction of fear attached itself to a stimulus or an object that was present at the same time, the horse. And even in the absence of the original unconditioned stimulus, Hans still had a conditioned fear response to horses. This is an example of a direct conditioning experience, a conditioning event that precipitated the development of a phobia. Hans would not have developed a phobia of horses if this event hadn't happened. It's a precipitating event. But different people have different likelihoods of developing a full-blown phobia in response to just one or two negative pairings. So one potential nervous system cognitive difference is the ability to habituate. And as a reminder, habituation is the tendency of our nervous system to stop responding with emotions or attention to stimuli in our environment that don't change or that don't convey new information. We're good at sort of tuning out and ignoring inputs that don't change. Whether or changes in the intensity or the frequency of an input captures our nervous system's attention because it means that something relevant might be happening. But if something around us isn't changing, we're not paying attention to it. So how can individual differences in the nervous system ability to habituate lead to individual differences in the likelihood of getting a phobia after a negative conditioned association? So an example from dog phobia, and again, most phobias develop in childhood, so I'm going to talk about how kids relate to dogs and how kids might develop these phobias. Many kids are nervous the first time they interact with dogs. This could relate to the behavioral inhibition system. We're all a little bit uncertain, nervous, hesitant when we're interacting with a novel stimulus or when we're in a novel situation. But over time, after spending usually not that long around dogs, most people will lose their initial initial emotional responses to stimuli that don't present new information. And so having a continuous interaction with dogs basically teaches people to habituate to typical dog behavior. You basically learn what is the range of dog behavior that I can ignore, that signals safety, that means that this dog isn't going to hurt me. When habituation is relatively poor, a child might not experience that habituation to dog behavior. They might not be able to learn what constitutes typical non-threatening dog behavior, and they might remain on high alert, anxious, and primed to have a fear response when they're around dogs. This can lead to more opportunities for pairings between the dog stimulus and a negative emotional response of fear. People differ, and part of this is based in the behavioral inhibition system, in their ability to form negative conditioned associations to driven by unconditioned stimuli that lead to fear. So as an example, lots of kids are scared of dogs because they can make unpredictable sudden movements like jumping and lunging. So it's pretty normal for a kid to kind of freak out when a dog jumps up on them, even though, you know, the adults around them might know that it's just friendly dog behavior. That initial experience of having a dog jump on you and having an immediate fear response can be enough for a kid who's at high risk for anxiety to form a conditioned fear association for dogs. Whereas that pairing of fear and a dog stimulus for kids at lower risk might not be enough to lead to the development of a conditioned association that could then turn into a phobia. Some people are just more primed to develop these associations than others. So if you had two kids, one who had a lot of biological predisposing factors and had a very enhanced ability to form conditioned associations, and another who had a more average ability to form conditioned associations to fear, it would take different intensities of experiences with dogs to get each of those kids to develop a phobia. The kid with more learning-related biological predisposition might be able to develop a phobia just with this one interaction of a dog jumping up on them, whereas the kid who's less biologically vulnerable, less predisposed to anxiety, might only develop a phobia of dogs if they had a truly dangerous or truly negative experience with one, like being bitten. So this could be due to a better ability to form conditioned associations, the brain just more readily latching on to danger and linking it to things in the environment that were also present when a danger was present or when a fear response was present. Or it could be because the child with more biological predisposition to anxiety had a stronger unconditioned fear response. And the strength of that response was maybe equivalent to the strength of the response that a typical kid or a kid with less biological predisposition would have to a more dangerous interaction. And parenting can play a role here too. So the way that parents react to stressful or scary things that happen to their kids informs how scared their child gets in that situation. So if parents kind of laugh off the dog jumping up and explain to the kid what's happening and teach them kind of how to calm the dog down and how to make the dog behave a little bit more predictably, that kid is less likely to form a negative conditioned association to dogs because they're experiencing that stressor as more controllable. Okay, another individual difference in learning machinery has to do with the tendency of fear conditioning to generalize. So in this interaction with dogs, you're interacting with a specific dog. Your nervous system could just learn a conditioned fear response to that particular dog. It doesn't have to generalize to a fear of all dogs. People differ in the extent to which their learned fear associations generalize to stimuli that are similar to, but not exactly the same as the original conditioned stimulus that was paired with an unconditioned stimulus and an unconditioned fear response. And a term for this is a generalization gradient. So this is the linear relationship between a person's fear response, a person's conditioned fear response, and the lessening degrees of similarity of stimuli to the original conditioned stimulus. So think as an example of a study where mice learn to fear a certain color light because that light is always on in their cage when they're given a painful shock. And we have 3 mice with different biological predisposition to anxiety and developing fears. All 3 mice are able to learn to fear what's known as the CS plus, or the conditioned stimulus that's paired with a negative unconditioned stimulus and a negative emotional response to fear. So all of them are a 10 out of 10 on the fear scale for that stimulus. But what if the researchers then turn on a light that has a similar wavelength, but not exactly the same wavelength to the light that rats learn to fear, or mice. Some mice, those who are more biologically predisposed and prone to anxiety, still have a relatively strong fear response, even though that stimulus was never paired with a negative experience. A light this color was never on in their cage when they were shocked. So for some mice, that's enough information for them for their nervous system to not generate a fear response, for their nervous system to say, okay, that's not similar enough. We don't need to fear this. We don't need to react. Or if we have any reaction, it should be moderate. It shouldn't be as strong as our reaction to the CS plus, to the light that we know comes on when we get shocked. And then light colors that get further and further away from that CS plus should induce weaker and weaker fear responses. But individuals can still differ in how much similarity the stimulus needs in order to induce that fear response. And individuals who are biologically predisposed to developing fear conditioning also experience their fear conditioning generalizing more to stimuli that are similar, but not the same as the stimulus that was paired with a negative unconditioned stimulus. So an example of this from dog phobia. So say we're thinking about this kid who doesn't necessarily have a ton of biological vulnerability, so they developed a dog phobia because of a genuinely scary experience with a vicious dog that bit them. Say that dog was a German Shepherd. It might be the case that that person would develop a negative conditioned association that makes them fearful and cautious in the presence of all German Shepherds because they look like the dog that bit them. There's a lot of cues from the way that they look and the way that they act that are similar to a dog that induced an unconditioned fear response for them. But typically in specific phobias, the phobia is not that limited. A phobia that's that focal and that narrow is less likely to lead to a lot of distress and impairment, because how often do you run into German Shepherds? Probably not as often as you run into dogs in general. So for people who are more prone to developing phobias and developing anxiety disorders, that fear learning to a stimulus that was present when they experienced pain and fear generalizes a lot more to stimuli that are different but somewhat similar. So this part is really crucial in not just how phobias develop, but how that initial fear learning persists and leads to impairment and distress. So the first process in the two-process model of phobias is associative learning, classical conditioning. The second process is operant conditioning. Operant conditioning of negatively reinforced behaviors are any behavior that is associated with a decrease in anxiety or a decrease in pain or a decrease in any negative experience is reinforced, and an organism is more likely to repeat that behavior. So as an example, in a mouse study, mice can be trained to press a lever because pressing the lever turns off a painful shock. When they press the lever, the shock goes away, and so therefore the behavior of pressing the lever is reinforced by escape from pain and fear. Because pressing the lever is reinforced, they're more likely to do it in the future. Similarly, when someone has a phobia and they find themselves in or approaching a situation that causes them phobic anxiety, they tend to try to escape and avoid that situation if they can. That avoidant behavior leads to a temporary decrease in anxiety, but it makes them more likely to repeat that avoidant behavior in the future. So it makes them more likely to continue avoiding situations that cause them anxiety, potentially leading to situations like the people in the dental clinic who had dental phobia and were there for really painful procedures because they had engaged in so much avoidance of dental care that they had to go to the dentist for an emergency. Individual differences can also influence whether someone experiences negative reinforcement from avoidance. So in addition to being able to learn negative fear associations, we can also learn safety associations. Our nervous system knows what environments are safe and what environments are dangerous. That's adaptive. Our ancestors had to know that to stay safe and survive. So when you have a conditioned fear association, that learning stays in your brain forever. Learning doesn't go away. But if after you develop that association, you have repeated neutral or positive experiences with the same conditioned stimulus that you initially learned to fear, you'll develop a second kind of learning called inhibition learning that competes with the fear learning, because you have new information that tells you this thing that you once learned to fear is actually safe. So rather than having a conditioned fear response to that stimulus, inhibitory learning, inhibition learning, or safety learning causes us to have a neutral or positive conditioned response instead. So for most people, most interactions with dogs are either positive or neutral. If someone developed an original pairing between dogs and fear, with dogs as the conditioned stimulus and fear as the conditioned response, it's because their nervous system learned that dogs signal danger. A dog was present when they had an unconditioned fear response. But if they go on to have positive interactions with dogs or neutral interactions with dogs, their nervous system is learning from that too. Their nervous system is learning that dogs are also present when things are safe. If that learning is deep enough, if it happens quickly, if it generalizes, if it is strong enough to compete with the fear learning, that person won't go on to develop a phobia. They have safety learning that overrides the fear learning that they acquired through that one negative pairing. In a specific phobia, safety learning doesn't occur through just kind of incidental daily exposure. Or if it does occur, it's not strong enough to compete with the fear learning. Some people are just biologically predisposed to have really powerful fear learning, and their nervous system weights fear information more highly than it weights safety information. They kind of err on the side of being afraid of things and staying away from things that their nervous system has associated with danger in the past. So environment and behavior can play a role here. If you had a negative pairing with a stimulus and a negative emotion, and then just because of your environment or because of your own behavior, you don't have any opportunities in the future to have neutral interactions with that stimulus, there won't be any safety learning to compete with the initial fear learning, and you're likely to have a fearful response the next time you encounter that stimulus. So avoidance is a super important concept that we'll revisit in every lecture in this anxiety unit. Phobias, like all anxiety disorders, are perpetuated and maintained by avoidance. When we think about humans, we think about avoidance as kind of an intentional, conscious behavior. I don't like this thing. It makes me feel uncomfortable. It makes me scared. I go out of my way not to experience it. The tendency to engage in avoidance is influenced by our beliefs about the world, our belief that we can't handle anxiety, our belief that danger is the likely outcome of any risky situation. Avoidant behavior, just like mice pressing a lever to escape a painful shock, avoiding situations that cause us anxiety is very reinforced because avoiding relieves our anxiety temporarily. How reinforcing avoidance is can be influenced by differences in inhibitory and safety learning. If it's harder for us to learn safety cues, we're more likely to continue to avoid. So throughout this lecture, I've been using the words predisposing, precipitating, and perpetuating to talk about the etiology of anxiety and specific phobias. We're going to call these the 3 Ps, but what you need to think about it, how you need to think about it is predisposing factors are underlying biological traits, life experiences, belief systems, and prior learning that all come together to make a person more or less likely to develop psychopathology. So in the case of specific phobias, having a really strong unconditioned fear response, having a sympathetic nervous system that just goes crazy in response to threat, individual differences in the ability to habituate to repeated stimuli in the environment, the ability to form rapid, highly generalized fear learning, and a weaker ability to form inhibitory safety learning are all predisposing factors to develop a phobia. Those things make you more likely to develop a phobia, but in the absence of a precipitating factor, an event that actually creates a pairing of an object and a negative experience, those predisposing factors alone are not enough to cause a phobia to develop. A precipitating factor is an event that directly leads to the development of a disorder. In the case of phobias, that's conditioning experiences. Perpetuating factors are what clinical psychologists mostly work with. Some of us work in primary prevention, so trying to reduce the frequency of different predisposing factors in the population. So working, for example, to improve quality of life for families means that fewer kids will have stressful experiences during childhood. That's a type of intervention that works on reducing predisposing factors. But when someone comes to the office of a clinical psychologist with psychopathology, what we need to do is try to modify the factors, the behaviors, and the cognitive machinery that's helping to maintain the symptoms of that disorder, that's perpetuating the symptoms, keeping them going, causing them to get worse. In the case of phobias, biological, cognitive, psychological perpetuating factors are things like the tendency to generalize fear learning beyond the initial stimulus. Impairments in inhibitory learning, meaning that future interactions with stimuli that were once paired with danger don't teach you to feel safe as effectively as they could. Beliefs about the world interact with these learning mechanisms and also influence our behavior. So if you believe that you can't handle anxiety and stress, that you'll fall apart, that situations are more dangerous than maybe they are, you're more likely to engage in avoidant behavior and engage in conscious behavior, intentional behavior that makes it harder for you to have safety learning experiences where a formerly feared situation is paired with new information that teaches your nervous system that that stimulus, that situation is safe. Okay, so some takeaways from this lecture. We talked about the difference between anxiety and fear. In the lecture from the reading, we also talked about the difference between anxiety, fear, and disgust. The adaptive functions of anxiety, fear, and disgust. Why do we have the capability to have these emotions? We talked about the biopsychosocial model of predisposition to and risk for anxiety. We talked about the clinical definition of specific phobia, what makes fear clinically relevant. We talked about the two-process model of how phobias develop, from precipitating events, classical conditioning, to perpetuating behaviors and learning, avoidance behavior, operant learning, negative reinforcement of avoidance. We talked about the role of individual differences in learning in precipitating and perpetuating phobia development. We talked about the importance of avoidance in maintaining phobias and other anxiety disorders, and we introduced the 3 Ps of psychopathology. All right, that was a lot. Thanks for bearing with me.